So I think it is worthwhile to talk about VAPs
Yeah.
in a little bit of, is that okay?
Yeah.
And then I'll talk about a little bit about trigger, because these are the essentials. I mean, you really got to dig down deep in the literature to find the basics, right? Like everyone will tell you a protocol that's fancy and laminated, which are fantastic because that's what you need for the sleep lab. And sometimes it's, you just need to know the basics, but to know how something works, you really have to go back sometimes to the Journal of Physiology in the 80s and look at articles by Stroll et al. So here's VAPs. So VAPs is VAPs. When I say VAPs, there's different types, right? There's AVAPs, IVAPs. What you do is you set it.
So step back. So ventilators themselves have 3 different modes. One is you hit a certain pressure, but depending upon your compliance of your chest wall and your lungs or your upper airway, you're just going to get to that pressure, and that pressure is all you get. So if you have a really compliant, it's going to open it up a lot, so big tidal volume or small tidal volume. Then the other one is volume, in which you just push in a particular volume, and that was the original bird ventilator that could be used in Vietnam. That was the really big, for trying to get people off the battlefield. You just have just push it in there and bring it back, but that doesn't care what pressure it is. So if you had a really stiff chest, it could increase your pressure a lot, and you could do that. Or if you had a really floppy chest wall, it would go in and it would stop and then it would go in again, and you could overventilate, right? And then comes along bi-level PAP. Now remember, that's a flow device. It's not a pressure or volume. Now you can say, well, volume gives you flow and flow gives you pressure, and this 3-dimensional gamish was in there. But I was involved in a patent fight between Respironics and a surrogate of ResMed in the early 90s, which they tried to sort of say, well, BiPAP is just double PAP, right? It's just, you got one pressure of PAP, and you got another pressure of PAP, and you go from that point to that point, right? That's all you do.
Yeah.
And so they were saying that that's what it is, and since there was no patent on PAP, there should be no patent on bilevel, right? So I mean, there was a lot at stake at that particular time. And so that's why this. So what that does though is it triggers and the flow goes up, and the flow is really all those things. It's your compliance of your chest wall, it's your airway size, it's how your upper airway is working, it's the whole sort of thing. And a volume just sort of jams it in, so the pressure goes way up. A pressure also jams it in, but a flow can have a trajectory, and that was why it was called a different valve. Besides the fact that the people on the other side, that they were the quote expert witnesses, were just they didn't present a very good case, because they sat there and said, well, everybody knows that a bilevel ventilator is a ventilator. And one of their other people was an author of a book on respiratory therapy and ventilators, and bilevel ventilation with a flow was never mentioned at all in any of the parts of the book, or in any of the index, or any of the things that had just been published the year before. So that was the key. You just show the table of contents. It says, is bilevel ventilation on here? And it would be no. Right? Would. On the other hand, I think what you have to think of is these are the things that you're trying to do. And that's what you're trying to show.
Right.
This thing.
So I'll show you, I guess, before I talk about VAPs, let's give you an example. Took me a long time to find this particular tracing, but let's take it slow. So on the top, you have airway pressure. Okay, this is the pressure if you're looking at like your CPAP or BiPAP pressure. Okay, let's say bilevel pressure, or you have your EPAP. Let's say the patient's on 20/4. Okay, so when they're exhaling, it's at 4, and then they breathe in, machine goes up to 20, it's there for a certain amount of time, and then returns to 4. And then the same thing happens. It notices the patient's breathing, it goes up to 20, holds there for a certain amount of time, and comes down to 4. Now, what this highlights over here is that on the bottom is flow. Okay, so up is inspiratory flow, and down below the midline is expiratory flow. What I always tell the pulmonary fellows and the sleep fellows as well is that in addition to what Keenan teaches us, which you have to be able to label, start by labeling everything on the page and top to bottom, left to right, but also I will add know what's up and what's down. Okay, so and it's actually not simple. Okay, I spent a lot of time in my studies lining, because I don't know, knowing what's inspiratory, what's expiratory. Sam has seen me do it in clinic. It seems to me an inordinate amount of time answering that simple question: what's up, what's down, what does it mean? So here you see flow, and I did it when I was preparing this talk. I said, okay, what is this again? So the 0 line is when you are not moving air, that's 0 flow. Okay, so this is where it says 0. Above that is inspiratory flow, okay, and below is expiratory flow. I just want to show you, if you're not a pulmonologist, you might not think about this. When you breathe in, when you initially breathe, there's a highest flow in the beginning, and then right at your end of inhalation, if you breathe in right here and I'm ready to breathe out, there's no flow, right? No flow, lots of flow, and then at the end of my breathing, there's no flow. Does that make sense? So here, if you just follow this before I tell you what this is, you breathe in, this is the beginning of inspiration, there's the highest amount of flow, the flow decreases over time, and then this is obviously using a bi-level device, so it's not going to be exactly like physiologic, but then it's 0 flow, and then you exhale, and as you're exhaling, you get to 0 flow again. So that's what this is. So inspiratory flow, and then expiratory flow. So what the device on a spontaneous BiPAP, okay, this is super important. How it triggers, again, trigger means going from EPAP to IPAP. How it triggers is usually by a flow, okay? And this is a parameter you set in the machine. It says trigger, and you put in something liters per minute. How many liters per minute does the machine sense that you're pulling in or inspiring for it to say, oh, you're breathing, you're inspiring, let's go to IPAP. So here, what you see is that you see this little inflection. This is the patient making their little effort, 0.1 liters per second of effort. And then the machine says, I see they're trying to breathe. Let's deliver the flow. So it delivers the flow to a certain point. And that point is whatever it takes to get to this pressure. So the flow goes up, the pressure goes to IPAP. And then the pressure we talked about, let's say this is the peak flow over here. Okay, so this is 2.2, 0.3, 0.4, 0.5, let's say 0.6 liters per second. It will continue at IPAP, right? As the inspiratory flow decreases until a certain point. You set that point, right? If this is 50% of the peak flow, you see that? If here's 100%, this is, I don't know, maybe 70. Actually, it's more closer to.
What's the decline?
The decline. What's that?
What's the decline to due to? Say,
due to essentially the compliance of the airway system. Once you start
the
getting
other one was adjustment.
Yes.
So you keep the pressure the same, and if you inflating a balloon, those. The push is okay.
So that's a great point.
And then it stops, and
then it stops.
And the balloon goes around the room.
Right. So then you tell the machine, oh, when it hits 25% of the peak flow, then go to EPAP. And that's what happens. It drops to 0 flow, and then expiratory. Then the patient exhales, and the machine notices that. And the patient starts to exhale until about 0 flow. Makes, in this case, so any questions about that? Okay,
And expiration is passive.
Expiration is usually passive.
It's not sucking it in the end, not sucking the air out.
Right. And so what I just want to show you when the flow drops, you drop to EPAP. You see that? So when this flow hits the certain percentage that you said and it dropped that you set it to drop, that's called the cycle sensitivity. When you have to have it cycle off, so then the flow drops and concomitantly the IPAP drops to EPAP. And that's to EPAP. So from 20 to 4. And it'll hold it there until the next time it's triggered. Here, what I'm showing is that sometimes if the patient's not, you can have an asynchrony of the trigger. Like here, you see the patient made an effort to breathe, okay, but it wasn't enough. The flow wasn't enough that it triggered the device. So this is a missed trigger. And then subsequently, you see again, this inflection over here, that was enough. That hit the line. And so that causes an increase in flow and a IPAP breath. And then again, another missed trigger. You see that again, what I would say is when you look at studies with neuromuscular patients, I look at the flow, but I also look at their abdomen. How many times is their diaphragm moving? And then how many times is actually a breath being delivered? That's another way to say, well, how well are they syncing with the breath? Yeah, Kim, you were going to say something.
So you can notice on your first breath there, the flow goes up, but there is a little deflection in pressure.
Yeah.
And there are pressure triggers as well as flow triggers. And in the MICU, you use the pressure trigger a lot more than you use the flow trigger. And then other interpretation of the end of the expiration is that if you go below FRC and you relax, you'll then have inspiratory flow. And you can do that yourself, blow all the way down to RV, relax. You get an inspiratory flow.
That's so through the chest wall.
Yeah.
Tendency, yeah.
It's unlikely to occur in those instances, but it may be, and maybe that contributes to it too. But it looks like it's much more like a asynchronous breath. And whether
You're talking about this,
that red, your red right there.
that you're blowing out to
A
RV.
little bit below FRC.
Oh,
Right. Well, if you're below FRC, when you end, so FRC is your resting point between
Yeah.
recoil, chest wall compliance. So anytime that you're not, I mean, that's the definition of FRC.
yeah. And I will say as a caveat, this is what Dr. Carol Rosen told me, but it's true. If you really want to understand these concepts, you still have to read through John West, pulmonary physiology. There are these charts. So you're not in pulmonary physiology necessarily, but I'd be happy to show you.
Yeah, that was probably in year 1, year 2.
Yeah, exactly.
I have a question. So how would somebody go below FRC if they're not forced to?
Actually, well, it could be that you're recoiling your chest wall is just very. Because your chest wall is pretty. I mean, it is pretty. Yeah, but it also has mass, right? It has mass, and it's unlike to do.
Right. So there are different factors, like in obesity, for instance, you have a load on the chest wall. If your chest wall is floppy, super compliant. Yeah.
The other is that kids, they have that funny chest wall. They never really reach RV. They go down and they interrupt. But that's not okay.
So any questions? These are super important. The terminology is important. Trigger is the start of a breath from EPAP to IPAP. Cycle is cycle. So I always say trigger on, cycle off. Cycles from IPAP to EPAP. And then we can go to VAPS if that's. Should we go to VAPS, Kingman?
Sure.
Okay.
Keep going.
So VAPS is volume. Sure. Before I go on the left, let me just take you through conceptually. Okay. So let's say you want a certain volume. You know that you want to say
You're a volume freak.
you're volume free.
You don't care anything except for volume.
Right. You will say minute ventilation equals tidal volume times respiratory rate take out dead space for let's keep it simple. Tidal volume times the respiratory rate. So I know how fast I can have the patient breathe. Either they'll breathe that way on their own or I'll set a rate, right? So I got the respiratory rate. But what about the tidal volume? Easy. I'll just deliver, I'll tell the machine, deliver a certain tidal volume, and that will give me the ventilation I need, okay? So the thing is that sometimes there's different pressures needed to achieve that volume. So what I'll do is I'll say to the machine, or I'll order the machine, give me a volume of 500 cc's, right? 500 mLs of air. Give that between an IPAP of 10 and 20, okay? Let's keep it small for argument's sake. And anywhere between 10 and 20 above your EPAP. 10 and 20, you can use whatever pressure you need to get that volume. Can't go above the pressure max. You can't go below, but anywhere between there, that's what you can give. So what I illustrate here is the green line is your goal tidal volume. Let's say that's 500 mLs. And so when you start off at baseline awake, the patient's breathing on this machine. It's using a certain amount of pressure support. Again, that's the pressure above the EPAP, and it's getting the goal volume, okay? But now what happens is you go to supine sleep, your FRC decreases, whatever reason your volume goes down on those pressures, okay? Volume has gone down. So what's the machine going to do in order to get the volume up? Increase the pressure, okay? So it increases the pressure, and as a result, your volume goes up. And now you're back at your goal tidal volume, and you're at a steady state. Pressures are higher than it was when you were awake, but that's okay. You're at a steady state. And now you're at a state where actually your compliance is improved. And so for these high pressures, what's going to happen? Your volume has gone up. You have better compliance. For a given amount of pressure, your volume has gone up, right? So now what's the machine going to do? It says, oh, we've overshot the target. Decrease pressure. And now you're back at goal and decrease volume. Okay, so that's what AVAPS does. It does that constantly throughout the night. It depends. The rate it adjusts depends on the device you use. Some are over minutes, some are breath to breath. One of the machines, the ResMed Astral, is 2 centimeters per breath, whereas the other one has an AVAPS rate, which says over the course of 1 minute, you can go change the pressure by 1 to 5 centimeters of pressure total, okay, over the course of a minute. So practically what you would do is that why? So what you do is you set an EPAP. Sometimes the EPAP actually can do an auto EPAP to make things a little more confusing, but it's got all the bells and whistles. You set to keep it simple, you set an EPAP, you set an IPAP range above that EPAP. So let's say your EPAP is 4, your IPAP will be 10 above to 20, let's say. So it'd be 14 over 24 to 24 IPAP. That's your IPAP range. You set an IPAP. So to do that, you need IPAP min, IPAP max, and that device adjusts the IPAP to achieve the target ventilation. And like I said, how quickly the IPAP changes depends on the manufacturer.
But why don't we use this more often than what I say OHS or mechanical ventilation in regular adults?
So there are papers that look at it, like Lisa Wolf from Northwestern has published on it, because essentially, like, there was, right. So the bottom line is our outcomes better, whether it's quality of life or survival or whatever you want to achieve. And so, there haven't been conclusive evidence, but there have been trends to say it's not inferior. And it depends. I mean, I will tell you, if you have a bad leak, then AVAPS doesn't know what to do. Like, it will think that it will just be at max pressure all the time. Not necessarily ASV. ASV's goal is to prevent hyperventilation. Correct. Like, its algorithm can't work, and so you sort of have to be conscientious. But for OHS, there's a school of thought, and they're publishing on it that says that it might be at least not inferior. I don't know if you have thoughts on that.
So you were, but they make you crawl through IPAP.
Yeah.
Fails for
UST.
right.
That's a great concept. from a practical point of view, the chip that's in the machine is the same chip for everything. It's just programmed. Within the machine. You've got CPAP, you've got APAP, ASD, you've got this, it's just the outside of the machine.
If you have to,
So if you could hack that, if you could hack that, you could hack that. You turn your
Now
CPAP
he's
machine
thinking.
Yeah.
well, yeah, you might end a couple warranties or something like that, but.
Yeah.
Anything else?
They don't, see, the problem with the warranty, it's only.
That's true.
Right? You replace your machine every 5 years, so.
So you got.
got 2 years out there, hanging off. the cliff.
So it's the same for CPAP too?
Uh-huh.
So what they call back and say it's broken in 2 years and 1 day. There it goes. Okay.
I have a question.
Yes.
So since you're setting essentially for volume assurance, you have a target volume, that's what the machine's trying to target, let's say 500. The point of setting the IPAP range, especially the max IPAP range, is to protect the lung. Is that what it's trying to do?
Yeah, essentially. So either protect the lung or at a certain pressure, the leak is too high and the patient doesn't tolerate it. There's some adverse.
What's the other adverse of too much pressure? What is it trigger? For the fellow, you know it, Moshe, but let's see what the fellow is.
Maybe the person up, or are you
There's-
throwing one towards like the.
What kind of disordered breathing could excessive IPAP cause?
Breath stacking? Or is that-
It could in an obstructed patient that's asthmatic or COPD, but probably more common. We see it all the time, even with CPAP. Too high a CPAP pressure, too high a BiPAP pressure could cause what kind of an apnea?
I'll send you back.
Right.
Non-obstructive apnea, then
You're triggering a Herring-Breuer reflex in this case.
I see. Okay.
Is that that's interesting because I was just studying, I just took my palm boards last week. And so what at least the textbook said is that Herring-Breuer is more for in infants and children and less in adults, but
Yeah, no, I mean, that's true. It's more in animals and in kids, it's more
but you
of
do
a
see it in
driving
adults?
reflex, right?
you could
Think of it as
test
driving.
Herring-Breuer to see when a transplanted lung actually receives.
Huh.
Yeah, right, exactly. So, but this is a manifestation of it in adults, if you will, right? We're
That's great.
excessively pulling on pulmonary stretch receptors, to basically turn off the inspiratory neurons and cause an apnea.
Great.
So Sushil, is there anything in his previous talk that you want to go back and emphasize? I have a few things, but
Oh, who's talking? Moshe's?
yeah, I mean, there were a couple slides there that.
Oh, yeah, no. I mean, I think this is like 101, which is perfect. I had a couple of questions more. That's probably 201 level, which is
Well, that's
about
okay.
respironics versus ResMed, because I don't know if Moshe, you want to, it's probably too much for this, but it's probably worth pointing out that they approach this very different in terms of how to adjust cycle and threshold sensitivity. ResMed, I think, gives you a lot more degrees of freedom, unless you know something about the new Evo trilogies. I don't, I haven't had a chance to play with those yet.
No, me neither. But I will say, just for the fellows, you have to know, again, what's up and what's down. Sometimes a percentage or a number, you always know what the units are and know what it means. But no, Sushil, I don't have anything on that for right now.
Now, the only other thing I think on the slide you showed about cycle and trigger is just, one other hint, and I don't know if I heard you say it. I got distracted for a minute, but just in terms of figuring out what's up and down, look at timing, right? Just look at, we know what's the normal I to E ratio. What from the fellows, what's the normal I to E ratio?
Isn't like 40-60? No,
It's close. 40 is what?
that's how.
Okay. He said inspiratory 40%.
Yeah, usually the traditional number we'll throw around is a third, but 1 part inspiration to 2 parts expiration. Yeah, Moshe presented this table earlier, which it's going to vary depending on your inspiratory rate, or sorry, your respiratory rate. But under normal breathing conditions, right, expiration is going to be longer than inspiration. And so when you're trying to figure out what's up versus down, the shorter should be inspiration and the longer should be expiration. So that's one other tip to kind of use when you're trying to figure that out.
But we have seen people come in with machines in which that's not the case.
Right.
And it is because they always throw the home care company under the bus. But they either change it at home or they change it. Others. So I had a couple things to bring up to think about. One is the rapid shallow breathing, just in terms of conceptually. This
Yeah.
is really conceptual. What's that due to?
So rapid shallow breathing take a step back. When you have ventilation, you have areas of the lung that interact with gas exchange and areas of the lung that don't interact with gas exchange. Okay, so think about the air. Sam and I did the alveolar gas equation and everything in clinic, but when you think about it, the air that's right here, when I breathe it in, and it's in my trachea, it's not interacting with gas exchange units. So the pressures, the amount of oxygen, amount of CO2 that's in that space will not change. It's going to be very similar to the atmospheric pressure. Okay, just to give you an example, how much CO2 is in the atmosphere? What percentage of the 760 millimeters of mercury is CO2?
Zilch, but it's increasing.
It's zilch, but it's increasing. So it's like 0.000, it's 0.004%. So it's almost nothing, but it's obviously has effects. But from pulmonary gas exchange, it's almost nothing, right? So that if you measure, if I put in a catheter or whatever and measure the air, it'll be similar in the trachea, it'll be similar to the air out here. The air in the lungs, let's say where you have the capillaries that are running through the walls of the alveoli, and the air has mixed venous gas, mixed venous blood going through those capillaries. So your CO2 is going to be 45 millimeters of mercury. Your PaO2 is going to be 40 millimeters of mercury. That's going to interact with the air that you breathe in, right? So think about the air in your alveoli. So in normal, does that concept make sense? So the areas of the lung that don't interact with gas exchange units, we call those dead space. It's just not interacting with gas. That's all. It's not contributing to your ability to get oxygen in or CO2 out. And the areas that do interact with the alveoli or the gas exchange units, that's called alveolar ventilation, or that's where you have alveolar ventilation. Okay, that's the term alveolar ventilation comes from. So the amount of hang with me for just a second. The amount of dead space in your lungs, anatomically, not talking about physiologically, but structurally, is fixed. You have your trachea, you have about 16 branches from the trachea down, 15, 16, that don't have any alveoli. All the air in there doesn't contribute to gas exchange. And so even if I increase my lungs, that amount of air in that, it's still 16 branches of bronchi, those are going to stay the same. So if you want to put it in concrete terms, let's say 150 milliliters of air is going to be not gas exchange. Okay, then in normal tidal breathing, let's say 500 milliliters. So 500 minus 150 is 350. Okay, that's tidal breathing. So in a tidal breath, 150 is not participating in gas exchange, 350 is. Now I have the ability to increase the volume in my lungs. Okay, and if I increase the volume of my lungs, the 150 stays the same, right? I'm not changing the real estate, right? That 150 milliliters stay the same, but if I get 3 liters inside my lungs, then I've increased the amount of gas exchange. So if I am, if my CO2 is rising for whatever reason, and I want to increase my minute ventilation. So what's a very nice way to do it is to increase the amount of volume in my lungs. And then for when I breathe in and out for a given rate, I'll actually increase my minute ventilation. Larger tidal volume, let's say for the same rate, will give me a larger ventilation, alveolar ventilation. Does that make sense so far? Yeah, I mean, it's a hard concept, but it's probably easier in a chalk. Can I use the whiteboard? Okay.
But the smaller your breath. the
Yeah.
more proportion is, that's.
Correct. So
the
if I,
larger your breath,
right,
it's smaller. So it's.
yeah.
I
So
mean, I think that's sort of the main thing to think of.
yeah, so let me just say for a second. So there's two ways of increasing minute ventilation. What we say the two variables are for minute ventilation: tidal volume and respiratory rate. So increasing tidal volume is actually very efficient because the amount of dead space isn't increasing, and I'm just getting more bang for my buck. I get more alveolar ventilation for if I keep my respiratory rate the same. If I increase the respiratory rate, then I've kept the proportion of dead space and gas exchange space the same. I'm just multiplying it, the number of cycles up with every breath. And so that potentially can be, if I'm taking small, let's say I'm restricted lung disease, I have small lungs, not a lot of air. And so the proportion to start with of dead space to alveolar space actually increase, right? Instead of saying they have 500 cc, let's say we talk about their vital capacity or their tidal volume is actually smaller. So let's say it's 150 to 150 for argument's sake, right? So it's going to be very inefficient to increase the respiratory rate.
And then they're really bad.
And then they get tired out.
Yeah, work on breathing.
And then they have acute respiratory failure. So that's, but they don't have the muscles to expand their chest all the way. So you see classically, let's say children with SMA, for instance, is that they come in, they're respiratory distress, and they might be maintaining their O2 and CO2 for a little bit, but they're like a train, right? They're just going. But unlike a train, they don't have, they have limited amounts of ATP, and they tire out. So long story short, that rapid shallow breathing means that you're not efficient. You're using a lot of energy and not getting a lot of gas exchange. So that some people use that index, rapid shallow breathing index, as a measure of how well you're ventilating a patient over time. And some of the ventilators read it out. It's not very good for kids that have small tidal volumes, but in patients with ALS, for instance, that is a way to see if my rapid shallow breathing index decreases over time, then I'm having more efficient breathing. So, and that goes back to sort of like the diaphragm resting. You're resting the muscles of inspiration and expiration by giving those bigger breaths and decreasing inefficient breathing. So that's a long answer to a short question, but okay.
So a question, so.
Yeah.
If a kid, rapidly breathing and you put them on, say, like AVAP, for example, and then if chemoreceptors are so used to breathing fast, they're blowing out all that CO2, and you're slowing down the breathing, all the treatment emergent essentials that occur, that confuse the picture there.
Well, then if you have, let's say, straight ICU, like they think they have that thought process, then yes, the child will have central apneas, and then
They'll slow down breathing too much.
and then they'll say, I mean, depending on the backup rate and everything, they might be okay. But yes, that we see that.
Sure.
We see that not only in any condition that you have chronically high CO2. So let's say very bad OSA, 4+ tonsils, obese, tonsillectomy, and then they can have central apneas from that. But certainly if they put them on aggressive settings, let's say they're still obstructing after tonsillectomy, you put them on settings. Yes, you blow down their CO2, they cross the hypocapnic hypocapnic apnea threshold, then they'll have centrals. Yeah, so it's something to be like, if you're consulting on one of those patients, you say, don't be too aggressive with dropping their CO2. What exactly, so they ask you like exact parameters, how to drop it. I don't know. It's,
Well, the other term to think about it is permissive hypercapnia.
Right, yeah.
So we don't want to talk about that in sleep. Okay. So, the other example that you had on, the EMG, the diaphragm EMG.
Yeah.
Yeah, right there. So you notice that there was a change in breathing frequency, but that was because NPPE turned on. You notice the EMG activity is sort of there, and it's increased work of breathing. It shuts off. So how, let me ask the fellows, how do you think you measure that EMG? You just accept it. You said, oh, it's good. So you're asked by me to measure the EMG of the diaphragm on somebody in the sleep mode. What would you do? What would you do?
Well, I guess from an ideal standpoint, you would insert a needle, but I don't think that would be the case. Probably just put.
They'd ruin your whole day to have an neuropillorax, right?
You probably just put a put a like a little read right here, right? And just kind of accept the artifact that may come above it, I think.
Artifact that might come above it.
Well, like the muscular artifact that you're not looking for in like maybe intercostals.
Yeah, it might be imprecise.
Yeah, less precise, that's correct. Yeah.
So you put it in the that used to be Prero put it in intercostal space. You'll see the early paper recordings. So you put an EMG here, but it doesn't really work out factors because you can't get that through. You put it over what they call the zone of apposition, which is between the diaphragm and the rib cage here, because your diaphragm does. So there's another way of doing it. We don't do it very well. This because we don't swallow balloons. You can swallow an electrode and put it down to your diaphragm and have it.
And that's not crazy. There's a mode of ventilation called NAVA, neuro activated something. Is you swallow a electrode, basically place an electrode in the esophagus, and it measures when the diaphragm is contracting. That's when it knows to deliver the breath. So that's.
Has anyone ever tried to like from the esophagus, like apply like an electrode in that regard to like, say for example, if you put like a thing around their chest so that it squeezes them so that it blows out more air, so maybe it increases their
Expiratory ventilation
yeah.
rather than inspiratory ventilation.
Because technically you can always get both, right? Because you get that recoil effect so that you don't need to have quite so much.
That'd be comfortable.
Well, maybe.
There's the iron lung.
It'd be comfortable that any patient that he's taking.
Well, the iron lung,
Every single time they take a breath.
Kingman is the iron lung,
It's
for
negative pressure.
but for expiration,
No, it's inspiration. It pulls things in.
and then its
Negative
expiration is passive.
pressure. Right. It hasn't done that. There used to be a thing like a shell. It was a
Yeah, curette.
abdominal cuirass. That would put negative pressure. Now, in terms of using expiratory, you only do that when you're resuscitating somebody and you push on the chest. There is an inspiratory, you recoil until you break the chest. Just remember that. Okay.
Sam, there are expiratory maneuvers, right, for cough augmentation, which we didn't talk about because it's more of a pulmonary talk.
Like
But-
opposites kind of things.
So the other thing that was odd to me that is in here, they picked that NIF of -40 or a MIP of -60 as being a threshold. That's not the threshold we use to take people off of ventilators. There's a mismatch there.
So that,
I mean, it must have been discussed in some patient paper.
yeah, the MIP, I don't have a good example for the MIP. I know that the cough peak flow, for instance, when they say is imprecise, right? So that's what they extract, it's extrapolated from liberating off of a ventilator in the ICU.
Right.
And so that's gotten translated into the guidelines to say the patient has a cough peak flow of less than 270 liters, I think per second, then they need augmented cough, because the thinking is if they are sick, then they'll be less than 160. And they're less than 160, you can't free a patient off a ventilator, which means that they won't have effective cough. So those things, a lot of those things are extrapolated.
There was an old lady that swallowed.
Right.
For a while.
I mean, that's what your point you're
No,
making, right?
you really have two talks. In there. One is mechanisms, and one's panic. So presenting it.
So what we do as a for this time, I thought about it.
Just know about it. I mean, you know, if you did a 1 hour lecture, you'd shorten one and lengthen the other, right? But trying to break it in half, just it's sort of like watching a train go by and trying to read what's on the side.
You spend more time going through the
One or the other, right?
so like really carefully going through something like this. And,
Yeah, right.
okay.
I mean, those are the practice. I mean, in the future, when you have time and effort and things of that sort.
Absolutely.
Or like this 9 to 10, you could break it into 2 and do a 9 to 10 in terms of practical stuff.
Hmm.
Yeah, I like people, putting that up and reading it, and trying to get the fellows to actually say what's, describe that slide.
I see.
Because then yeah.
Oh, yes, I think the first slide like this that you put up with the pseudo central,
Yeah.
my question was just, it almost looks like it's obstructive with the flow, like on the nasal transducer.
Yeah, it is.
It is.
Right, so.
So it's not central at all.
Yeah. So
This
like a
this
central-
has been a term. So in this article, Luke Fiabasuan, who's in the he's at CCF and he's
This one?
yeah.
Oh, Lucy, yeah.
Yeah. So this is his paper.
It's not a central hypothesis, it's a with central components. So
Correct. So what he writes is that people have called this, it's a misnomer. It's not a pseudo central.
Right.
So he says it's that, it's probably more appropriate to call it diaphragmatic sleep disorder breathing, like whatever it is. Your point is
You're
correct.
trying to call it something else that it can be.
You just need to describe this, that people don't make the mistake to say this is essential. You're correct. There's decreased chest involvement, there's decreased and so is this, you actually raise a good point. Is this obstructive or is it something else? And King and I have talked about, I still have to sit down with you, but the question is, how do you determine the type of thoraco-abdominal asynchrony? Because there's, like I said, there's at least 3 mechanisms. One is airflow resistance, either upper or lower. One is increased chest wall compliance. So when you breathe in, your chest wall will be floppy. Another one is decreased lung compliance. So looking at the tracing, you have to say, gee, how could I figure it out? So Keenan, I have to sit down with Keenan, and he said there are indices that we can look at to figure that out.
That's ribcage abdominal motion, relative motion. In this particular instance, he picks out a right diaphragm paralysis, which by itself usually has no importance. But during these phasic events, it sort of shows the vulnerability of take out the intercostal muscles, and you already have one diaphragm repaired. Because a right diaphragm paralysis will not result during wakefulness in a change in your abdominal motion, but inspiration while you lock down. It will still go up, so you can't detect it now.
But without esophageal manometry, can you say for certain that there's no upper airway?
No, esophageal manometry or transdiaphragm, that's how you tell if they're making efforts. That's really what you're trying to look for.
Mhm.
Because and there was articles in the 80s when you could do that easily.
Oh,
It showed
right.
that 20, something like 40% of all things that were called central were really obstructed. Right, because you could see little transdiaphragmatic pressure, which means that there is some sort of force that's produced to be able to do that. You swallow a balloon to the stomach, and then you would swallow a balloon to your mid-esophagus. The difference between the two. And if you take a breath, there's no difference. And is that the chest wall pressures as you breathe in is transmitted directly to the abdomen. Anything resisted is not diaphragmatic paralysis, and that's the only way to really do it. You know, this sniff test or whatever it is. This is an area that the radiologists don't understand. They can detect, you know, whatever. Okay.
All right, thank you, guys.
Thank you, guys.